So I'm very pleased to invite Alec Price-Forbes, who is the National Chief Clinical Information Officer at NHS England. We also have Ellie Asgari, who is a Senior Clinical Scientist at Newton's Tree and also a Consultant Nephrologist at Guy's and St Thomas Hospital. We have Keith Grimes, who is a GP and also founder and CEO of Curistica. And last but not least, you're probably wondering why Carl McRae looks a bit different, but Carl couldn't be here today and he sends his apologies, and we have Haris joining the panel as well, who you're all familiar with. So we've had some fantastic talks thinking about that kind of national perspective, touching on what monitoring looks like, and we're now moving to a panel discussion, and we want to think about not just are AVTs safe, are AVTs unsafe. I think we'd like to try and really bring out that conversation around how do we make the whole ecosystem safer for AVT adoption, and how do we actually tend towards responsible AVT adoption. And as part of this, we're going to be thinking across the AVT adoption pipeline, thinking about what responsible implementation looks like, then thinking about what responsible monitoring looks like after the go-live or deployment of an AVT, and then third, thinking about what responsible response to any safety issues or failures might actually look like. And I've got a few questions for the panel across those kind of themes, and we'll be thinking about that local versus national perspective, and also bringing in what things look like in primary versus secondary care as well. I'm going to pass over to the panelists to kind of give slightly more in-depth introductions, but also I'd like to ask the panel to think about, in kind of 1 or 2 minutes, what are the kind of main top 2 or 3 things that you're most concerned about, as we might overlook kind of key issues when we're thinking about AVT adoption. So think about your kind of main top 2 or 3 challenges. And then also, before I pass on to the panel members, can I just get a quick show of hands to figure out who's in the room? So who's here from NHS settings, including clinicians? Amazing. Who's here from health tech or other organization? Okay, cool. So we have a good mix, which is great. So I'm looking forward to the audience Q&A. So I'm going to pass over to the panel. I think it's probably easiest if we start from Keith and work our way backwards. So Keith, a brief introduction and a bit about kind of what your main top 2 or 3 concerns might be.
So hello everyone. You recognise so many faces here, but for those I don't know, my name is Keith. My background is a GP. I've loved technology all my life, way before I got interested in medicine, and I still love it. Along the way, I've been trying to deploy technology for my patients and the people that I care for. It's been successful sometimes, difficult in other times, and I did that within the NHS. I did that working at Babylon for 4.5 years, and in 2022, I realized that if I really wanted to shift the needle on getting great technology out there, we just had to make it safe. And it seems like such an obvious thing, and people all say they want to make it safe, but they do precious little to do so, and they don't really know how to get into it. So Curistica, the company that I founded, helps with clinical safety for people building, buying, or deploying technologies, such as ambient voice technology. And your question is sort of the 2 things on my mind. The first of which is that AVT is an almost miraculously unique thing in the sense that this is technology that people actually want to use. It's almost, I can't remember any technology other than the ones that geeks wanted to use, which is fantastic, and it can make some really big differences. But the thing that I'm concerned about is that we miss this opportunity to do it right, because people are leaning into this. They really want to use it, and they want to use it correctly. So there's a responsibility we have to do so. The second thing that concerns me is we teach absolutely nothing to people working in healthcare about technology. We teach them a lot about almost everything else, drugs, doctors, nurses, devices, but not technology. And we're fighting a bit of a rearguard action here to try and introduce people because they're interested in AVT. But this is our opportunity to get the foundation right. Whatever the technology is, understanding how to use it safely is going to allow us to unlock the thing that the little boy in me wants, which is to use all these great toys and things to help people, but we have to do it right.
Fantastic. Thank you very much for starting us off. Ellie?
Yes. Thank you. So similar to Keith, I know several people in the room. Thank you very much for coming. So I'm a nephrologist, as you said, and I have been interested in safety in medicine for a long time. And since I started my work as a consultant, I realized that I'm really interested to deal with incidents and incidents reporting and do root cause analysis, which sounds crazy. But then I became the governance lead, and I was the lead for 10 years, thinking about what are risks in medicine, how we react, how we respond, how we investigate, and the regulations and rules that we have in the hospital and in healthcare to deal with them. And then a few years ago, I saw the wave of AI coming. I was very interested to know more about it, so I took some time off to get a master's in AI in healthcare management. And at the same time, I found about Haris and his work that he was doing in the clinical computing team at Guy's and St. Thomas's, and I was very interested to work with him. And I started working at the Ambient scribe company called Tortoise. That was in 2023, before they were a thing, to understand how they work, and then did some studies about how to monitor them and understand how they make mistakes and what is the best way to look at the mistakes, where they impact, and how we can mitigate them. And then when there was an opportunity to work at Newton Street with Haris, I took it very quickly, and I felt very lucky to be able to work in the company and look at use of different AI tools and how we can monitor and then bring the expertise and experiences that I had together, looking at safety, AI, and monitoring the AI tools in the longer term. Coming with the Ambient scribe and what my concerns are, I think very similar to Keith. I feel like this is a technology that I can see a lot of clinicians really want to use. This is something that has come from the bottom up, not from the top down. But my concern is also the lack of education. I don't see why this has been such a difficult thing. We have a significant problem with digital literacy, I think, in the NHS. And I think it wouldn't have been so difficult as this technology is being used to produce something nationally as a simple education, not very sophisticated. You don't need to understand AI deeply to understand how the technology works. But that would help you understand where the problems can happen as a clinician and be able to identify it earlier before it gets to more deeper issues, societal issues that we later on would be talking about. The other thing that does kind of concern me is the monitoring afterwards. You know, working in governance for a long time, a lot of times when you have a new technology or anything new coming, you may not realize the consequences of using it until further down the line. And understanding where to look, how to look. Haris was saying earlier, you think nothing is happening, it's because you don't know what is happening. You're not monitoring, so then you wouldn't see it. So these are some of my main concerns, along with some others, which I'm sure we will address.
Fantastic. Thank you very much, Ellie. Over to you, Alec.
Thank you, and thank you for having me. Good evening, everybody. I think we stand between you and some drinks and networking, so we'll get on with it. But I'm Alec, National CCIO, but also one day a week I'm a consultant rheumatologist. So yesterday morning and yesterday evening, I was treating patients, not using AVT, because I've followed my own guidance, and my trust doesn't have it yet. And despite numerous offers, I've declined them for that reason, for good governance reasons. But I was struck, particularly in the morning, by the amount of tapping on a computer I was doing. And I think the exciting thing for me is how ambient voice, as Keith and Ellie described really, is the first time in certainly my 30-year career that people are wanting to actually use the technology because they can see the potential benefit of, rather than us documenting care and dealing with the enormous administrative burden that has come upon us with the technology we've deployed, that it will create time to care. It will bring back the humanity, the human-to-human interaction that actually patients deserve. So I think it democratizes the consultation process, which is at the heart of the healthcare system, and is a potential game changer if we get it right. What concerns me is we've got to do this. We've got to learn the lessons of the last 25 years, I would say. I've just had the pleasure of being up in Colchester, 7 months post their go live of an EPR. They've done a tremendous job, but I think they've learned the lessons of where technology and particularly EPR implementations haven't always been done well because people have been focused on maintaining productivity and activity. And what we need to be doing is shift towards how do we measure outcomes and benefits for patients, and how do we measure data quality. So everything we do should be aligned to the 3 pillars of the forthcoming quality strategy, and that is it should be safe, it should enhance experience, both for the caregiver, but most importantly, the customer, the patient, and it should be effective, it should be impactful. And if we're going to do that, we need to be responsible about the way we scale new technologies, but specifically ambient voice technology. And what we need to think about is the intersection between clinical safety, governance, information governance, and technology assurance frameworks, and how this all needs to gel together so that we can create confidence and trust, both for the public as well as for health and care professionals across the system, and make sure that what we are doing is consistent, it's standardized and replicable to deliver safe, quality care that is impactful and improving the lives of those we treat. So the opportunity here is really creating, the government wants the NHS to be the most AI-enabled healthcare service in the world. Some of you will have heard me talk about being a musician by background. I'm a violinist, played in lots of orchestras. We've got to bring all of the members of the orchestra, and that's all of us, and the public as well as patients on this journey of building a responsible, trustworthy, agentic architecture from which we operate a new NHS, because the symphony that really inspires me is how do we become the world's most socialized, integrated, personalized, digitally enabled but data-driven health and care system that's a learning health and care system where the best of science, technology and AI is really enhancing people's lives. And that's the end game, a prize that's worth us all fighting for. Thank you.
Fantastic. Really, really nice to hear that national angle as well. Haris, over to you next.
Yeah, I'll just talk about what I think is important. I'll pick one thing, and it's actually not about technology at all. I think, I often get asked sort of informally to help with the hospital's AI strategy. And when I used to lead AI at Tommy's, I used to have the 3 Ps, which was people, platform, and policy. And people is becoming an existential issue in this country. And a lot of the processes and all the cool tech that we have or dream about won't work unless we have the right workforce to adopt it and implement it. And one of the things that we haven't done so well, and we've done lots of things actually really well when it comes to tech adoption, especially when I compare it to sort of other economies in Europe and in the US, is invest in workforce upskilling. And I see around the room, there's a lot of NHS AI fellows. Nick, can you put your hands up if you're an AI fellow? Charlie, Nick, Tom was here somewhere as well. So the NHS AI Fellowship Program, despite its name, was never actually centrally funded. It was part of that Matt Hancock wave of the AI lab funding, but not a single pound of that 250 million was spent on direct education. The NHS Fellowship arose because I needed doctors to label data during the pandemic. That's the reality of how the fellowship was born. And I got 50 grand to buy out fellows time for 2 fellows at Guy's. And then a few months later, somebody asked me if I had a curriculum. And so I quickly rustled up a curriculum. And then the London Deanery said, oh, by the way, we've got £500,000 underspend. Do you want to make it a London AI Fellowship? And I said, sure. Like, I'm a physicist. I've got like the arrogance of a physicist. I'm sure I can figure this out. And now it's in its 5th cohort. And it's the world's only education program for resident doctors and other mid-career healthcare professionals. And we're in the middle of exporting it to Singapore and Kaiser Permanente in California and in Houston. And when I was invited to talk about it in California, I thought it was very funny that the NHS was teaching Californians about AI. But the lesson here is that even to this day, the education program is not centrally funded. local organizations, professional societies, and we go around cap in hand every year to get them to chip in to do something that's better for everyone. And I know, and everyone's very excited about AVTs, but if it's really going to deliver in the promise, for anyone that's listening or elsewhere, maybe there's a slice of that funding which can be invested in upskilling. That would be my major concern.
Brilliant. So we've heard quite a few different themes. So a bit about the workforce, monitoring, coordinating things nationally. I wanted to just touch again, still continuing on the kind of theme of implementation at that kind of early phase of getting the AVT in. And I wanted to, I guess, go to Keith and Alec first. So Keith, can you tell me a bit about what things look like in the kind of primary care setting versus secondary care? So you have an AVT, as you mentioned, lots of people want to actually use this new technology. What does the adoption look like in primary care versus secondary care? What's the same, what's different, and what key considerations do we need to make when we're actually getting these technologies in?
Yeah, it's been very, very interesting to observe it over the last year or so, and thank you for your letter dated 9th of June last year, which came out. I've been working in clinical safety for a long time now, and as I was doing this, we thought, well, actually, maybe the issue is to try and solve this for the manufacturers, because the manufacturers obviously need to build these safe products. And then when speaking to them, found out that some of them hadn't done some of this work, and I asked why, and says, well, we're not being asked about it. We're not being asked to do this. And that seemed odd to me, but it wasn't totally surprising, because it's what we've seen. So there are questions about secondary and primary care. We'll start with secondary care first. I'd worked and done clinical safety work at scale before, but hospitals and secondary care organizations were better set. They already had departments, they'd had information governance, they'd have their governance committees, and so on, and they'd frequently have clinical safety officers. So they'd already be up and running, but were they keeping up with absolutely everything? And so as Yusuf, who works with me at Curistica, as we were talking about this conundrum, we said, well, I wonder how many people are actually doing this. And this is what led to our observations that we found and published in the JMAR last year, where we looked and we asked under FOI hospitals and trusts in England about how many technologies they had, how many were compliant with the standard, and how many CSOs they had. And I've got the numbers here. I still haven't committed them all to memory, much to my shame, but I'll make sure that I've got them all here. So 239 we contacted, 211 responded, that's 88.3%. About 15,000 technological deployments. What did we find? 70.1, that's 70.1, had no DCB 0129 or 0160 for those deployments as well. And I was slightly shocked. Not surprised that there was a gap, but slightly shocked. And this is an organization that actually had the teams already, and there was a lot of variability in how many staff they had for this. ICBs, which were the closest we get the primary care side of things, didn't fare really much better on that. I don't have any figures for primary care because that approach wouldn't work, but I do a lot of work in primary care, and of course I'm a GP by background. I can tell you that the number is not going to be any better than that, because previously the work was done by secondary care people that were procuring it for them, and I think that's maybe part of the issues. They think that for this technology it's done for them and therefore it's all right, but of course that's not the case. And then further to what we learned last year, or people increasingly learned last year, as clarity emerged about how to approach ambient voice technology, there was a kind of period of sort of stunned not knowing what to do. But now we're seeing practices starting to work with this. So we do work with practices and PCNs and federations. And it's been here and there, people haven't been clear on what to do, but now you're seeing practices realize that they want to use AVT, because everyone in the practice wants to use AVT. One GP said with his practice, they would rather take a pay cut than lose AVT, is the way he described it. And so they want to get that in place, but they realize that they want to get this right, because what they really want are some other technologies, because AVT is good, but there are really pressing problems that are causing them major headaches that they kind of can't unlock first. So we're seeing it gear up, but they don't have the funds for this. It's been landed on their lap. There's no special funding for it. They don't know what quite to do. They're training up, and of course they have no training from when they've been at medical school or undergraduate level or postgraduate about it. So there's an awful lot of education happening through being asked to get these great things out in front of them. It's like, this is a great opportunity to get the foundation right. So there's that side. The hospitals and secondary care are gearing up for this as well, but I'm seeing the fastest acceleration in primary care, and I'm not surprised because primary care is awesome. It was the seat of innovation for many decades anyway. But to see them wake up to this and start push into it is really gratifying.
Can I quickly ask though, is the rapid adoption in primary care partly due to the sort of product-led growth motion that a lot of these companies employ, which is to give it out for free to individuals? And so then you have the uptake, but does that not create headaches for you later down the road, because suddenly you have lots of people, for all the right intentions, using technology that they enjoy and think it's better for outcomes, but without the appropriate processes in place?
It make your head spin what's being used out there, and it's true. I mean, the technology's out there. In part, it's about that, the people having access to it and not maybe understanding what questions they should be asking, whether they should be using this technology, and so on. But even outside medical technologies such as AVT, people are using ChatGPT, Claude, like they're just the shadow use of AI. I think it's 20% aren't using it based on it in some form out there. And they have no idea that this might fall under the same thing as well. But again, background as a GP, I'm practical on this one. What's the quality of care we're giving right now? If we can get some of the foundations in, then in the same way Alastair was talking about, you don't step out your front door and not get punched in the face because it's against the law. It's because people know how to behave. If we can get people to know how to behave with technology, with one technology, then maybe they'll bring that into their shadow AI use or everything else. And ultimately, everything's going to get safer. So that's the kind of approach.
Yeah, brilliant. No, based on what you've just said and also Haris's question, I think one of the, key themes here is that variability. And I'd like to ask Alec a question around kind of national coordination versus maintaining some element of local decision-making around kind of the procurement of various different technologies. And as Haris popped up a slide, I think we had, 103 or something like that, AVTs available on the market. And I guess, so Alec, my question is kind of two things. The first is really thinking about how do we get that level of national coordination whilst maintaining local decision-making for those kind of, local variability in the need for different devices. And then the second part of that is really thinking about how do we prevent people from reinventing the wheel. So as Keith said, there's massive variability in how things are being handled from a clinical safety perspective, thinking about the DCBs, et cetera. So is there a way for us to kind of start sharing that learning and making sure that everyone's on the same page?
Yeah, no, great question. So I think, and Keith referenced really the guidance we published last year was really trying to get ahead of what was already a burgeoning area. So I think it's fair to say that it's not really whether AVT is a promising technology at all. It's about how do we scale it in a safe, replicable, consistent way to make that a standard that we build trust and responsibility and create a learning health and care system that really is innovating around the use of AI. And that's the opportunity if we get this right. So I think we were intervening on the basis of recognizing that within the sovereignty of an organization, and you referenced the difference between primary care and secondary care and the challenges there, but also within ICB systems and regions, we've had lots of discussion with regional medical directors, regional digital delivery transformation directors, looking at how we set the standards, how we need that consistency around governance and assurance to ensure that procurement is not inconsistent and a good value for taxpayers, but also leads to consistency and uptake in safe deployments. So we've been looking at how do you do that from a national standard, but also recognize that there's huge variation when you look at the regions, look at systems, look at individual providers and organizations, community settings, huge variation in the way people have deployed technology and how they're using, what their current level of digital maturity is. So we need to get the fine balance between trying to do things from a national perspective in terms of saying this is the direction of travel. We want this to be a safe, standardized, consistent way, adopting all of the appropriateness around digital clinical safety, DPIs, etc., and trying to do things once where it's appropriate to do so, but recognise there needs to be each region and each system needs to be tailoring it to their needs. And particularly when you start looking at ambient voice technology as an example, for me this is not a productivity tool that is simply reducing note keeping and documentation. We've got to be more imaginative, that this really does, in Bob Wachter's words, enable us to reimagine health and care delivery, because it democratizes, if you like, it's creating a computation of the patient's story. And our patients have told us for decades that they don't want to repeat their story. So there is nothing innovative about me as a rheumatologist seeing a patient after 9 months and diagnosing their complex multi-system autoimmune condition called vasculitis. When they've been to a GP practice 6 times, they've been to A&E 4 times, and they've been to 3 other specialties within the hospital who finally said you need to see a rheumatologist. I could look at 13 summarizations, but really? Is that the best we can do? The opportunity is, how do we properly scale this, but actually architect it in a safe, replicable way, so that we actually start to capture the patient story once and add to it in a chronological way. And that's the way, if we get this right in a safe, responsible way, but build confidence both with the workforce, but most importantly with our customer, with patients, then we'll actually start to create a narrative upon which other AI we can leverage benefits from. So, for an example, AI triage tools should be using high-quality data coming from the patient to triage them to self-serve to the right information if they're feeling unwell, or to the right service, or to a rheumatologist if they're having a flare of their rheumatoid arthritis. We've got an opportunity here, and we need to do it in a thoughtful, responsible way, but with safety, experience, and impact being our measurable sort of North Star vision that we're aiming for. So I think we're trying to do that. We recognise there are some areas of the country that are further ahead, but I think it's fair to say at this point in time it's inconsistent. Let's be honest. Not everybody is using an ambient voice technology at the moment, myself included, but we should be. That should be the future we're aiming for. So we need to standardise approaches around procurement to get value for money. What I don't want to see is neighbouring hospitals or neighbouring ICBs going through a procurement with a supplier and getting different variables from that. So we need to be thoughtful about that. I think you picked up on, we've got to be sure about not just digital clinical safety and information governance and the sort of technical assurance frameworks we need in terms of digital maturity, but how are we monitoring? How are we monitoring and then sharing and learning from that sharing, so we become a learning health and care system? So there's a lot to be thoughtful about, and this is not just about a point solution that is going to enable more patients to be seen. It will enable that, but it should fundamentally change the way my daughter, who's a first-year medic, is being trained to be a doctor, because it's got the potential. I sort of refer to it a bit like learning to drive a car. We all learn in a manual car, most of us. I'm now driving an electric car. I hate going back to a manual car. I tell all my patients to get an automatic car at the very least, because I don't have to deal with their shoulder problems then from changing gear all the time. So there you are, bit of MSK advice for free. But the point is, there are times when the lights will go out. There are going to be times when we want safe prescribers will need to go back to pen and paper and write on drug cardex. So we've got to balance training the workforce, as Haris said, for this future, which is really exciting, that reimagines health and care delivery, but at the same time making sure we've got all of the robust governance and safety in place, but we also train people to do things in the traditional way as well and get that balance right.
Fantastic. No, there's lots of really, really important points there. I'm going to, before I come to Ellie for monitoring, Haris, I wanted to pick up on the workforce training aspect with you. So obviously we've got the opportunity now to really start redesigning medical school curricula, training doctors right from the start to begin thinking about not just AVTs, but also kind of other technologies, AI for imaging, etc. One of the things, and then we've got kind of national initiatives such as the fellowship that you mentioned. I guess, what would be your main suggestion for those who aren't doing fellowships, they don't have that medical school curriculum? What would you point them towards? So obviously we have a massive workforce that will inevitably end up using these AVTs. Where do you see that going? What's the role of kind of mandatory training, etc.? Sorry to put you on the spot.
Yeah, that's a horrible question. Yeah. So the truth is, I don't know, right? I didn't go through any structured program for AI ever. Which see some shocked faces. Like I am like completely self-taught expert, and I get asked quite a lot by people, whether they're consultants who are not eligible for the fellowship program or people who are in med school, like, hey, what resources are there out there that we can look towards? And the reality is there isn't. There aren't a lot, and there's none that I would be like, oh, that's a good one, I vouch for that, go and do that online course or MOOC or whatever. But that's also not how I learned, and obviously I'm biased by my own experience, but the way I learned was just by doing. The very first algorithm I developed at Tommy's was to help hypoxic ischemic infants at the Evelina Children's Hospital. I built it on my own laptop and I deployed it on a Mac that was sitting in the radiology reporting room. And I learned Python myself, I learned what a neural network was myself, and then I learned that I shouldn't be doing these things without telling people. So that's my experience, and this is one of my bugbears with the fact that was me in 2015, and it's been over a decade, and there still aren't. I mean, I know there's pockets. The BIR has stuff, the RCR has stuff, other people have stuff. But it's not good enough. It's all in the fringes. And when it comes to mandatory training and sort of business as usual education, I really don't know. AI literacy, to me, is one of the hardest challenges out of all of AI education. I'd rather supervise an AI PhD student than to do AI mandatory training. And the reason I say that is somebody who's coming in for an AI PhD has done a STEM undergraduate and probably a master's. They've probably done math science at A-level. When you're trying to do AI literacy across a workforce as diverse as the NHS, people come from all sorts of walks of life with different kinds of educational backgrounds, and trying to understand what they should know today and what is still relevant for them to know is a really hard challenge. We run a course around risk management around AI, and we're constantly having to change, or I'm constantly having to change, because the ground is shifting underneath us. So that's a really bad answer to basically say, do it yourself.
I think Keith was going to come in and bail you out.
Yeah.
And I'll just keep this really brief. Totally agree. I think
Who taught you, Keith?
No, I didn't. And this is the point I'm going to make. Like, first of all, it's ludicrous that you can go to medical school in the UK and 5 years from now come out based on the curriculum they have right now and have no core component that covers these technologies. So, 5 years from now, the doctor's coming out, if they choose not to attend any of the modules that are optional, they'll have learned nothing specific about this. I think that's insane, right? So we've got to fix it. We've got to get some space in there. However, what I've learned about AI, and I struggle to teach people to it, I use it a lot, and I actually now think that there isn't any easy way to teach AI. You just have to use it. But that doesn't mean you just drop someone into it. And so I think the way into it is just giving people enough so they can use it safely and let them work out the rest, if I'm honest. And I know that works well for geeks that would do the same, but I think everyone finds their way into it that way because it becomes so hard to explain why it's powerful until you experience it. And so how do you square that? I just tell people to use AI on their hobbies, and then they're off to the races. But yeah, so sorry,
that's great.
Ellie.
That's great. I mean, user training is, I guess, one part of the solution, and monitoring is the next, right? So, Ellie, I wanted to come to you and really, I guess, move from that implementation. We've now got an AVT in, we've deployed it. We need to try and make sure that we've got the most robust monitoring set up as possible. So once an AVT is about to go live, I guess we need to start thinking about it before we've actually deployed. What does monitoring look like? What does good look like? And I guess, where do we start?
Yeah, thank you. Can I, before I come to monitoring, I have strong views about
Go for it.
Mandatory training. I actually feel that, as medics particularly, and all healthcare professionals, we're all used to studying. You do courses every year. You have to do I have to do mandatory training for lifting stuff off the floor, which I hardly ever do. And so, why can't we? And yes, it is hard. But being hard doesn't mean we can't do it. And I think, when I started my learning AI journey, I started from lots of different courses, from the basic, as in like A plus B, very, very simple, to more and more advanced. And I think there's no way to say that we can't do it. We can design a course that everybody from the first year can learn something and have an idea. And then later on, and if anybody wants to learn more, kind of direct them to that. Now, coming to the monitoring, I think monitoring, I always like to, for ambient scribes, I always like to break down how the ambient scribe works, and that's why I think education is so important. So if you break down how the technology works, as in you have the voice that comes in, then that voice is using speech-to-text technology to make a transcript, and that transcript is then goes to an LLM and comes back as a summary. If you have these steps, then you can think in each step what can go wrong, and then all of that, then you can have step 1, monitor audio, step 2, monitor the transcript, step 3, monitor the summary, and the last step, look at how the doctor is now editing the last bit, that is AI summary. So I would say that for monitoring this technology, you need to look at all these steps. And the last bit, which I think we don't think about a lot, is about how this is then going to change our behavior, which is something we think a lot about at Newton Street. And I think this is something, unless you think about it carefully, have a team of, system behavior scientists to help us understand how technology changes our behavior, wouldn't be able to understand it. Need to think about what signals we need to think. We are now at our hospital, we're trialing like an ambient scribe, and I find myself talking differently. I think, so then I have to repeat whatever the patient says, or repeat something that is in my head to make sure that it's capturing it, or repeat my examination about their blood pressure to make. So how is that, at the moment, I'm just kind of playing with it because it's a trial. How is that over the long term going to impact? So all of those things is very interesting. I was listening to, there was a talk this afternoon about ambient scribes at the AVT community, where the professor of behavioral psychology was talking about this, and was saying they were from the US, and they were saying about this coding, that they use ambient scribes for coding. And then he was saying that they've done this study that because in the US you have to pay for every problem that you have, then some patients are advised not to talk about some of their problems, because then that would code, so then that would bill. So imagine, how indirectly it can impact your behavior on what you speak about. And thankfully, we don't have that issue in the UK, but there's so many things that can come out of this. It's important to us to be vigilant, be aware and sharp, and think about, as we go along, use technology safely and think about the unintended consequences as well.
Yeah, it's a really, really interesting point, and obviously draws out some of the differences between the US and UK markets as well. Keith, you wanted to come in?
Yeah, but that happens without technology anyway. Patients coming in saying, oh yeah, Dr. Keith, I have for the last 2 weeks had a pattern of altered bowel habits. People don't talk that way, but they had come, people even before AVT would talk in this way. These are just different manifestations of it. But I do have a story to warm your heart. Just last week with one of our clients was doing a bit of follow-up as they've implemented some AVT, and the person who was running it said, and we've been looking at the usage. There was an AVT that was being used, and it provides a report of edits. And they said, look, I've looked at the number of edits made by the doctors using this, and look, this person's only editing 3% of the notes, but someone's editing 95% of the notes and everything. And we talked about it in the safety work, but I was thrilled to see that they were actually doing something about it. So they were then going to go off and try and find out what happened. When manufacturers put that tool, that's part of it. When that tool's available to the users, it's one thing to say to do it, but they have to have the tools to make it easy. And this is proof positive of it actually happening. So, I think there's a lot to be positive about here. People know how to do governance. They just need the tools and the time to do it.
No, that's super interesting. And if I can ask a follow-up question, I am keeping an eye on the time so we have enough time for audience Q&A. But if I can ask a follow-up. So at the moment, we know that there is this kind of gap in reactive approaches to monitoring. So when you look at the number of AI technologies being used, including AVTs, and then you look at the number of adverse events being reported and coming in, there's clearly a gap there. We don't know exactly what's causing that gap, although we can hypothesize. But we also know, based on what you've mentioned, Ellie, that there are a lot of different things that we can monitor proactively. I guess my question is, what's the balance? How do we try and detect subtle changes that don't necessarily lead to adverse events but could in the future? And how do we make sure that we're picking them up and identifying unsafe technologies as early as possible? And perhaps Ellie, Haris, and I can open up that up to the panel as well.
So I think one of the common challenges with AVTs is hallucinations and omissions. And I know that several of the ambient scribe companies are looking very carefully into that. They are trying to reduce the hallucinations, identify omissions. And that's one of the things that I think every clinician who is using the technology needs to be vigilant about. And there are ways that you can monitor it at source with the technology itself. So that's not so difficult to do. And then with regards to other things to monitor, as Haris was saying, for example, using the audio, that's what we've been trying really hard to do. Then there are ways that you can, similar to what we have for radiology, you can, develop automatic monitoring, so you don't have to have individual looking at it. So you can develop technology to monitor your technology to essentially highlight if something isn't being correctly recorded. So those are the ways that you can do it relatively easier. Then the other things is some of the things you have to do regular audits or periodic audits. And again, with education, I think unless you have the good education to people understand, then they can report what's happening. So.
Oh yeah, I was just going to say, when I was 15 and I got my first job at Marks and Spencer's, there was in the manager's office there was a poster that said, "To human is to err. To really f things up, you need a computer." And the reason why this is relevant to monitoring is. With all digital technologies, for those who have had the pleasure of doing a safety case for those, when you go through that risk analysis and you look at the consequences, and it's, is a single person going to die or are multiple people going to die? The trouble with digital technologies is that once there's a problem everywhere, right? It's a fungible technology. It's not like a surgeon with a scalpel who can only kill one patient at a time. You can cause a lot of harm to a lot of people. And so then proactive risk management becomes critical. It's not enough to wait for there to be an incident that gets reported, because if there is a systemic issue, it's everywhere already. And so then proactive monitoring, looking at proxy measures, so that consultant or GP who tends to not inspect the summary so well compared to his colleagues, that needs to be investigated before there's an incident. Because by the time he calls or she causes an incident, they probably caused it to many people's records. And that's the other important bit. And so then the challenge for us as an ecosystem, both nationally and locally, is what are the thresholds? How alarmed and sensitive do we need to be to these fluctuations? There's natural variations in care. And that's some of the R&D that we're doing at the moment with some of our clinical partners, which is how do you keep an eye on things but without being sort of like a helicopter parent?
Fantastic. I'm going to bring Alec in just to respond to that. And then whilst Alec and Keith respond to Haris, if everyone can start thinking about their questions, because we are going to go to audience Q&A very shortly.
Who in the room would like me to prescribe you 50 milligrams of methotrexate? You wouldn't.
Just bash, yeah.
15 and 50 sound very similar when using voice to text. So just picking up on what Haris just said, we've got to avoid humans on the loop and be clear that this is humans in the loop. The responsibility clinically, whether I've generated a letter using voice to text or whether I've sent a letter to the other side of the world to be transcribed by somebody, that's what used to happen in my trust before I went to voice to text 6 years ago, or whether I've used an ambient voice technology, the clinical responsibility lies with me to look at the output. Because it matters. If it was your mum or dad or your brother or sister, or your wife or husband, or your child, you'd want that consultation to be captured accurately. We have an opportunity to do it. We've absolutely got to put all the monitoring in. I loved your description of really training the workforce, health and care professionals, to understand the difference when you're using Teams, that audio capture and automatic speech recognition and transcription and diarisation, Keith said this, Alex said that, Haris said that, is not the same as summarisation. So we might be thinking about, I could say lots of ums and ahs, and shall we think about going on holiday? Becomes we've agreed to go on holiday. That's an inference taken by AI. So we've got to be clear that when we're having a consultation with a patient, there is a human in the loop. This will speed everything up, but we've got to make sure that we eradicate that historic behaviour, which I agree with. I remember going around when we got rid of paper results 13 years ago. I went around every specialty and found lots of brown envelopes with thousands of unopened results, because nobody looked at the results. They waited until the patient came back to the clinic or got admitted to the hospital. This is the problem we're trying to solve. So the way we've operated historically, comes back to the training piece, is no longer acceptable. It's got to be that every touch point with a patient, we're extracting the crude oil. Data is crude oil, but data is only relevant when it becomes meaningful, usable, and useful information upon which we make decisions that create a safe, experiential, and effective outcome for the patient in front of us. So that's the opportunity we've got in front of us. The second thing, if I just may, is that, again, ambient voice isn't just about that point. The biggest bugbear for me is the 10 minutes on average that I spent yesterday for each new patient requesting orders, prescriptions, referrals, and other stuff in the EPR whilst the patient was there. And I kept trying to have niceties, but then thinking I've got to remember to what I'm requesting, etc., in the dreaded EPR. AI and agentic architecture and AVT is going to enable the very unusable systems we put in to be more usable. But we've got to check the outputs. If I'm prescribing methotrexate, if I've said that in the consultation doing a refill, then the prescription in the e-prescribing system should say methotrexate 15 milligrams once a week. It's a red flag drug. I've got to check that. It's my responsibility. But that 10 minutes should become 1 minute. So all those referrals, the orders, the prescribing that happens, that takes time, should just be rooted up. So we've got to move away from just thinking about AVT as a sort of summarization, note-keeping tool. This should transform our experience in terms of an overburdened, from an administration perspective, workforce, as well as the experience for the patient, but speed everything up and enhance quality and the relevance of documentation, the quality of documentation in the EPR. So that's the opportunity. So we're calling it 0 to 3, transcription just being phase 0, summarization being phase 1, advisory coding being 1B, integration into workflow so that the letter goes into the system, you're not copying and pasting it into the wrong record, being 1C, and then 2 and 3 are where you're getting automated workflow and enhanced clinical decision support. That's the direction of travel, and that's really super exciting. But we've got to make sure we do it in a responsible, safe, assured way with appropriate governance frameworks, putting clinical safety at the forefront and making sure a human is in the loop.
Fantastic. Keith, did you want to come in briefly, or is it a burning one, or do you want to... Okay. Let's go to audience Q&A. So we are going to have a mic or two roaming around the room. I think there's one just there. On the panel, we're going to have to share mics, if that's okay.
Hello, can you hear me?
Yes, go for it.
Hi, I'm Bash. I'm a radiology consultant. One thing, I'm moving to New Zealand. In New Zealand, they've got AVTs in every emergency department there, but they've also got specific explicit consent for the patient rather than implicit. That implies that you have to have understanding of what's going on, otherwise it can lead to people being averse and not using it. That implies a degree of patient education, and I'm not sure I heard a lot of that yet, because I do think that's something that's not particularly looked at, and you can see that on a wider context with digital exclusion, with broadband and things like that. But I do wonder about how do you see that going forward?
That's a fantastic question. Any of the panel Go for it.
So I think there was a publication from NHS how we should be consenting patients. They said that it should be implied consent. However, they have explained that we should be telling patients what it is. Patients need to be informed about the use of the Ambient scribe. And best practice is that you tell the patients, I mean, it's very hard to explain to the patient in the 10-minute consultation or 15-minute explain exactly how technology works. But how I would see it is that there should be a national move for patients to understand this. And that came out in the public dialogue that Robin very skillfully organized and ran, that and patients wanted this. So we should have, similar to, on your NHS app, you have a lot of information about lots of different, or on the NHS websites, there should be information for the patients. And a lot of places that are now using the scribes are having information for patients. I've heard from speaking to a lot of GP surgeries that they have information for patients as a way of leaflets, as a way of posters, so then patients can understand what it is, read about it, and ask questions.
Yeah. Who else here is watching The Pit? Yeah? All right, okay. It's fantastic. A bit of a Westman's holiday for medics. Yeah, of course, yeah. Anyway, but the point I'm going to make is in season 2, no spoilers, there's quite a thread about ambient voice technology in there as well. So part of the education is simple, put it in EastEnders. I know I'm not being flippant in here, but we have to demonstrate this, putting like education and pieces of paper and stuff like so what? Like, we've got to get it out there and people know about this side of things as well. And it will eventually happen. The other thing is that informed consent only works if the clinician knows how to explain what's going on as well. And I think we've still got some work to do there.
And great question, incredibly important. When I'm doing voice to text, I'm looking at the patient, but dictating and explain what I'm doing them in advance, that I'm doing that and what will happen. And they look with marvel as the words appear on the screen, etc. So it's the next iteration, isn't it? But we've absolutely got to bring the workforce as well as the public and patients on this journey to build trust and confidence and reimagine. So this is the opportunity, but absolutely, it's the person's data at the end of the day. So it's really important that they understand what we're doing, what happens, what the outputs will be, etc., and how we'll be using that information. So incredibly important point.
We've got a couple of hands up. Should we go to this chap in this third row first, and then we'll go to this side?
So you wrote my question down, I'm trying to find it. Hi everybody, my name's Aditya Agarwal, pharmacist by background. Completely love the point about the push within the undergraduate education. It's something I've personally been trying to push in our pharmacy profession because we're playing catch up with the medical world in terms of getting AI, talking about it more. My question is slightly different to maybe some of the topics being covered here, but most trusts are in a really tricky financial position, and they can't see, you can't see fewer patients basically, because seeing the number of patients is how a service gets paid, and that's how hospitals essentially are able to afford their bottom line. But there is obviously an issue with improving patient experience. We know that's a problem as well. So how do you see that? How do you see trust trying to reconcile those two competing areas? Because you get hammered more the central team hammers you for finance and not be able to meet that, and why you're not seeing enough patients, when I think, Alec, your last point was actually you need to have longer appointments, and therefore you could argue you're seeing less patients in a clinic than currently seeing.
So just, are they counting how much it costs them for staff churn, hiring new staff, burnout, sickness, and so on as well? Even before you look at the downstream harm to patients and deaths as a result of burnt out doctors and nurses and so on. It's difficult because that's seen as a different pot. But for goodness sake, we've got a technology now. Like, when was the last time we saw technology that actually made people feel better about using it? Not just the patients, but the clinicians treating them as well. And that's almost all the studies that come out talk about the time savings. And they can be high or low and everything. But they're uniformly talking about people feeling better as a result of it. And I know some people maybe don't like AVT too. It's just a plea that we have to consider that, because every member of staff that is off with moral injury and patients that are fobbed off and come back in has cost down the line. But much like incidents, we're not measuring that, we're not counting that, therefore we don't value that too. So I don't think here you go straight to the board and demand that they do that, but we do have to consider it.
Gosh, so I don't personally think that consultation will be longer. I think we should be more measured and considerate of the customer, the patient, in explaining what we're doing, but that doesn't mean it has to be longer, just doing that due diligence. I think we need to be focusing, and we haven't really talked about, obviously, different care settings, and even within care settings, there's going to be a differential we need to explore and really consider and think about. So how a nurse will be operating in a obstetric suite versus on a ward versus what a resident doctor will be doing versus what I'm doing in outpatients, all very different, let alone before you start looking at ED. And we've got some really compelling evidence coming from the Southwest region, Centre of Digital Excellence in Bristol. John McCormack, Steve Trowell have done some great work actually looking at just acoustic variation within a simulated environment and looking at the impact of babies crying or toddler noise or construction noise or rain, etc., on the pickup and outputs from the same summarization. So I think we need to be considerate that this is not a panacea that we can just throw it in and it's going to work. We need to think about each setting, outpatients being one area, call centres being another area, ambulance being an area, ED being an area, and lots of other settings. My personal view is shift-based services, when we talk about productivity, is probably the easiest place to demonstrate that productivity gain. We've got 7.4 million people on a waiting list. We recognise the challenge and the unsustainability of the NHS in its current guise, but we've also got to recognise, as Keith alluded to, that we've got 1 in 10 leaving the NHS and a burnt-out workforce who are doing lots of pyjama time, preparing for clinics and other activities. So we've got to balance this, and I think it's about ensuring it's safe, assured, delivers benefit, but also enhances experience, not just for the patient, but for the health and care professional who is providing that care. And I think if we get that experience back, we'll start to generate goodwill again, because I think we've exhausted goodwill in the NHS. So I think there's a balancing act. It's not a precise answer. There's a challenge. We are expected to be delivering the 2.2% productivity gain, but I think we need to be a bit more strategic about the areas where that can happen. I think the flow of patients on urgent emergency care pathways from call centres, the already compelling work that David Davis has done with London Ambulance, so looking at call centres, ambulance into ED, is a natural place where you could be really impactful and improve flow, decrease dispatch time for ambulances, etc., etc. So lots of really compelling evidence there. I think outpatients, it will come, but I think first of all, what we need to do is my 4-hour clinic should be 4 hours and not 5.5 hours, as it is now. That'll put a smile back on my face and a spring in my step. And if we get that, we'll start to be more productive and more efficient. Same for general practice, I think. So I think we just, general practice even more so from a contractual reform perspective, given the challenge for primary care colleagues. So I think we need to be thoughtful and get a balancing act and just work as a system and recognise there'll be some areas and some care settings when you get that productivity gain more immediately, just through a bounded, responsible, trusted way of doing things versus other areas where you need a bit more thought, outpatients, changing clinic templates, job planning, etc. These all need to be considered as well as the environment in which you're working.
Can I make a quick comment about money? As an early stage founder, I'm very conscious of money and cash flow. Appreciate the fact, particularly in secondary care organizations, everybody's in the red, right? Even historically wealthy organizations like Guy's and St Thomas's, which is my own. However, every year, about almost £3 billion flows through Guy's and St Thomas's. There is money in the NHS, right? The question is how can we be more creative around collaboratively working together to find where the cashable value is? And having now done similar business across the UK and US, there's a real difference, and the difference is not because US health systems are richer. The average cash on hand that a US health system has is something like 17 days. So the average US health system is 17 days away from bankruptcy, and they go bankrupt all the time. The thing that I have found that is very different with how American health systems do business is that they are very transparent, usually, about their profit and loss. They say, hey, look, you're selling me this benefit, these are my costs, this is where I'm feeling pain. Let's come to an agreement of how you can be fairly reimbursed and I can capture value that stops me going bankrupt. And I feel like the way that we do procurement and the culture around commercial negotiation and procurement is not a collaborative one. In fact, it can be unnecessarily combative. And so you have really well-meaning vendors on the other side who think they can help, but they need counterparts on the health system to be transparent and collaborative and to say, hey, look, if you can make it look like this, then we can work together. And if not, at least they know what target they're aiming at. At the moment, it's very hard for us to understand as an ecosystem where those cashable savings are. But there are, because we spend billions of pounds on healthcare all the time.
Brilliant. I think we might be able to squeeze one more question in. I think there are a couple of hands up on this side. Yeah, should we get Robin?
I'm a cyber psychologist, so I work in the area that Ellie was mentioning earlier about the system behaviour change. And we've heard a lot about time saved as being a metric of success for AVT. And I just wondered, so putting the kind of the well-being, however you define that, benefits in general practice, in secondary care, what I'm seeing is that a lot of the clinicians are actually being told that they're speeding up their work and therefore they can just get more done, because the ones I've spoken to, they're not taking breaks in the time saved and they're definitely not clocking off early. So where is that being looked at within the pathway?
I can take that, because very good question, and a lot of studies have actually looked into that, because as the question before, there is not so much productivity gain as in money, particularly in secondary care using this technology, because you can't, if I see 12 patients, using AVT doesn't make me see 13 or 14. It just makes me, instead of spending another 4 hours editing my letters, spend 2 hours editing my letters. And a lot of studies that have looked at the benefits of ambient technology have looked at the cognitive load, like benefits for the clinicians, and everybody is showing benefit, like study after study showing it. But then I think the challenge is that how do you make that money? And it's very, very difficult. You can't say, oh, my clinician feels better, so I'm going to pay more. I think you need to think very differently, and it's not going to happen in the NHS, unfortunately. But I think, you need to find somewhere else, as Alec was saying. So I think in emergency care, in ambulance care, in a lot of that type of services, it does increase. You can see more patients, and they have, studies have shown that it works. So perhaps you can have some productivity, like actual money gain there, and then, use that benefit somewhere else.
Another tantalizing thing, and so I worked in clinical governance for a long time, and I realized that the better the notes, the better the defense. I am hearing from medical legal colleagues that AVT is leading to much more defensible claims because of the quality of the note keeping. Not in cases where AVT was raised as the cause. They haven't mentioned those, but the documentation, access presentation, and I worked in out of hours for many, many years. And when people are worried about recordings, I've been using recordings almost my entire career, working out of hours. All calls are recorded for training and managing purposes. But in that place, we didn't question it. And I'll tell you something, doing governance, having an audio recording 99% of the time helped the clinician defend, what were, problematic. Also caught out a few naughty ones too, but it does help. So I think that's maybe to put in there as well. Maybe the technology could reduce the medical legal costs.
Fantastic. I'm going to close the panel there. I think we've had fantastic, and we have some resources that we are going to share with everyone, and we'll make it available after the event. And also there is a booklet that Keith has just flashed up, which has the kind of basics on AVT, and also it has like an example incident, which is a very, very interesting part of that as well. So just to close, I think we've seen that actually choosing the right AVT is one part of the solution, but actually making sure that the system is ready for AVT adoption in a responsible manner is actually perhaps the more challenging part, making sure that we have the right workforce training, we've got the right clinical safety standards being used, and we've got the right and robust monitoring strategy in place. I think the panel members will be around for a little bit longer for the networking break, so if you have any burning questions, please do corner them. But at this point, I'd just like to ask for a round of applause for all the panels.